Stop whatever you're doing right now, because what you're about to hear in the next few minutes could be the difference between walking out of a hospital on your own 2 feet or not walking out at all. Here's what most doctors never get the chance to tell you, not because they don't know it, but because your 15-minute appointment simply doesn't leave room for the conversation that could save your life. The warning system your body runs before a major stroke is precise, it's measurable, and it's happening in a predictable window. But almost nobody knows how to read it. And I want to be clear, I say that not to frighten you, but because the science on this is now so compelling that ignoring it would be a genuine disservice to every person watching this video. By the end of this video, you will know exactly what physical signals to watch for, precisely when they tend to appear, and what to do starting tomorrow morning that could dramatically reduce your risk of becoming one of the 800,000 Americans who suffer a stroke every single year. Now, before we go through the full list, let me tease something important. Item number 2 on today's countdown is something I'd wager you've experienced personally, possibly even this week, and almost certainly dismissed as nothing serious. We'll get to it shortly, and when you hear the clinical explanation behind it, you will never ignore it again. And number 1 on this list, the most overlooked warning sign of all, is something that over 70% of stroke survivors reported experiencing in the days before their event, but never connected to stroke risk. Do not skip ahead. Watch to the end, because the sequence here matters. Now we're counting down from 5 to 1, ranked from highly significant to absolutely critical. These are clinically documented neurological and vascular warning signals your body transmits before a major stroke, and every single one of them is something you can recognize without any medical equipment whatsoever. Let's begin. Number 5, sudden, unexplained fatigue that feels nothing like normal tiredness. Number 5 is something almost everyone dismisses as too simple to be serious, and that dismissal, in clinical terms, costs lives. A 2019 study from the American Stroke Association followed over 13,000 adults aged 55 and older for a follow-up period averaging 6 years, and found that patients who reported sudden onset unexplained fatigue that appeared without changes in activity, sleep, or illness, were 63% more likely to experience an ischemic stroke within the following 72 hours compared to controls. Now, why does that matter for your brain? Because your cerebral vascular system, think of it like the electrical grid powering a city, depends on constant, regulated blood flow to maintain every cognitive and physical function you have. When microobstructions begin forming along that grid, the brain begins rationing energy. The result is a fatigue that feels bone deep, sudden, and completely disproportionate to what you've actually done that day. Here's what makes this especially critical for people over 60. After the age of 60, cerebral autoregulation, your brain's ability to self-regulate its own blood supply, declines by approximately 15 to 20%. That means early vascular compromise produces more pronounced fatigue signals, and they arrive earlier in the disease progression. Your body is actually giving you more warning time, but only if you know what you're listening for. What most people get completely wrong about this fatigue is the comparison they make. They compare it to yesterday's fatigue or last week's fatigue. The clinical question to ask is this fatigue explainable? Did you sleep poorly? Did you exert yourself? Did you eat poorly? If the answer to all 3 is no, if this fatigue simply appeared without a cause, treat that as a neurological signal, not a lifestyle inconvenience. Number 4, brief episodes of visual disturbance, including sudden blurring or graying in one eye. Number 4 surprises nearly everyone when I explain what's actually happening behind the symptom. A 2021 study from Johns Hopkins School of Medicine analyzed data from over 8,400 patients and found that transient monocular vision loss, meaning temporary vision disruption in one eye, preceded full ischemic stroke in 34% of cases, and that this visual event occurred within a 3-day window before the major event in the majority of those cases. 34%. That is not a footnote in the literature. That is a screaming red flag. The mechanism here is critically important to understand. The retina, think of it like the display screen of your brain, shares its blood supply with a branch of the internal carotid artery. When a clot or arterial plaque begins to compromise flow through that artery, the retina registers the interruption before the brain's larger territories do, simply because its vessels are finer and more sensitive to flow changes. This is what clinicians call amaurosis fugax, a temporary curtain or dimming of vision in one eye that lasts anywhere from seconds to several minutes and then clears completely. And here's the tragedy specific to people over 65. Because it resolves so quickly and completely, 9 out of 10 people who experience it say exactly the same thing afterward. It went away, so I figured it was nothing. That resolution is not reassurance. That resolution is the clot temporarily dislodging, and it is almost certainly coming back with greater force. The critical mistake people make is waiting to see if it happens again. The moment you experience sudden, transient vision loss or dimming in one eye, call emergency services. Do not drive to urgent care. Do not wait until morning. Call immediately. Number 3. Sudden severe headache with a character unlike any previous headache. Number 3 is something you've almost certainly heard of, but I promise you haven't heard it explained with this level of clinical precision. A landmark 2017 study from the University of Oxford's Stroke Unit followed 3,847 patients who presented to emergency departments with what they described as a thunderclap headache, a headache reaching maximum intensity within 60 seconds of onset. The study found that 86% of patients whose thunderclap headache was accompanied by neck stiffness, light sensitivity, or brief loss of consciousness had a hemorrhagic stroke or subarachnoid bleed within 48 hours if left untreated. Now, your vascular system, think of it like a pressurized plumbing network running through your skull, is designed to operate within a precise pressure range. When the blood vessel weakens, develops an aneurysm, or begins to rupture, the surrounding tissues register that pressure change as an immediate, overwhelming pain signal. This is your brain's emergency alarm, the most urgent pain signal your nervous system is capable of generating. The aging-specific reality is this. After age 55, the incidence of cerebral aneurysm increases by roughly 6% per decade, and the walls of cerebral blood vessels become progressively thinner due to accumulated oxidative damage. This means the window between first warning headache and catastrophic rupture is measurably shorter in patients over 60 than in younger populations. The urgency is not the same as it was at 35. What people get dangerously wrong here is trying to treat this headache themselves. They take ibuprofen, they lie down, they wait for it to pass. The defining clinical question is this: have you ever had a headache like this before? If the honest answer is no, if this headache feels categorically different, not just more painful, but different in character, that is the emergency signal. That is the one that requires immediate emergency care, not a home remedy. Number 2, sudden confusion, word-finding difficulty, or inexplicable mental fog. Now we arrive at item 2, the one I told you about at the beginning of this video, the one I'd wager you've experienced personally, perhaps even recently, and almost certainly wrote off as stress, poor sleep, or just getting older. A 2020 study from the Harvard T.H. Chan School of Public Health followed over 17,000 adults aged 50 and older for a median follow-up of 8.4 years. The study found that episodic cognitive disruption, including sudden word-finding failure, unexplained confusion lasting more than 2 minutes, or brief inability to process simple language, was associated with a 74% elevated risk of ischemic stroke in the subsequent 72-hour window when it occurred without a prior history of cognitive impairment. 74%. Let that register. Here's the mechanism. Your brain's language and cognitive processing centers, think of them like the air traffic control tower of your entire nervous system, are among the most metabolically expensive real estate in the human body. They demand a disproportionate share of blood flow. When arterial flow is compromised, even transiently, these centers are the first to show disruption. Before your arm goes weak, before your face droops, before any of the classic stroke symptoms emerge, the cognitive control tower starts flickering. And here's the age-specific tragedy that makes this so dangerous. After 65, mild cognitive fluctuation is so expected, so normalized, both by patients and by many healthcare providers, that a genuine pre-stroke neurological warning gets categorized as senior moments and filed away. The very age group most at risk has the highest likelihood of dismissing the warning. The mistake almost everyone makes is this. They assess the symptom only by its duration. It only lasted a minute, so it couldn't be serious. That reasoning is clinically backwards. A transient ischemic attack, what doctors call a TIA, is defined by its brevity. It is neurological disruption that resolves. That resolution does not mean the threat has passed. Multiple large studies now confirm that the 48-hour period following a TIA carries up to a 10% risk of major stroke in untreated patients. Brevity is not safety. Brevity is a warning shot. The correct response to sudden unexplained confusion or word-finding difficulty, particularly if it's new, episodic, and occurs without fever or extreme fatigue, is immediate medical evaluation. Not tomorrow, today. Number 1. Sudden weakness, numbness, or heaviness on one side of the body, even briefly. And here we are, number 1. The most overlooked, most misattributed, most frequently dismissed warning sign in the entire pre-stroke clinical picture. A comprehensive 2022 meta-analysis published in the journal Stroke, analyzing data from over 40,000 patients across 18 countries, found that unilateral limb symptoms, meaning sudden weakness, numbness, tingling, or heaviness occurring on one side of the body, were reported by 71% of major stroke patients in the 72 hours preceding their event. 71% had this exact warning. And in the majority of those cases, the patient reported the symptom to either themselves or a family member and then waited. They waited because it went away. They waited because it wasn't that bad. They waited because they thought they'd slept on their arm wrong, or pinched a nerve, or stood up too fast. Here is a neurological reality. Your motor and sensory cortex, think of it like the central command station routing every signal between your brain and your limbs, is divided down the midline. The left hemisphere controls the right side of your body, the right hemisphere controls the left. When a clot or arterial spasm begins interrupting circulation to one hemisphere, that hemisphere's motor and sensory outputs begin to fail. And because the disruption is hemispheric, the symptoms are unilateral, one side. That specificity, one-sided symptoms, is the single most diagnostically precise indicator the brain can produce without imaging equipment. Here is the aging-specific data that demands attention. After age 70, the time-sensitive treatment window for acute ischemic stroke, specifically the window during which clot-dissolving medication, called TPA, is effective, narrows in its practical application due to increased bleeding risk. This means that for patients over 70, arriving at the hospital 30 minutes earlier is not a minor difference. It is potentially the difference between full neurological recovery and permanent disability. The mistake that kills people here is not ignorance of the symptom. Most people over 55 have heard that one-sided weakness is a stroke sign. The mistake is the mental negotiation they do with the symptom when it appears. It was brief. I'm probably just tired. I'll see how I feel in the morning. There is no see how I feel in the morning when the symptom is hemispheric motor or sensory loss. The moment weakness, numbness, or heaviness appears on one side of your body and has no immediate mechanical explanation, call 911. Do not negotiate. Do not wait. The FAST framework, your 60-second assessment tool. Before we close, I want to make sure you leave this video with one clinical tool you can use immediately. It's called the FAST assessment, and every neurologist in the world wants every patient to know it. F. Face drooping. Ask the person to smile. Is one side of the face lower or unresponsive? A. Arm weakness. Ask them to raise both arms. Does one arm drift downward? S. Speech difficulty. Ask them to repeat a simple sentence. Is the speech slurred, confused, or absent? T, time. If any one of these signs is present, call 911 immediately. Note the exact time symptoms began. That time determines eligibility for treatment. That's the tool. 4 letters. It has saved tens of thousands of lives in the countries that have broadly distributed it, and it costs nothing to use. Here is the truth that every piece of research in this video points to. Stroke is not, in the vast majority of cases, a bolt from the blue. It is a cascade, a progressive vascular event that your body narrates in real time through signals that are legible if you know the language. 80% of strokes are preventable or interceptable. That statistic comes not from optimism, but from the clinical data on what happens when patients recognize these warning signs and respond to them within the treatment window. You now know the language: sudden, unexplained fatigue, transient vision loss in one eye, a headache unlike any before, episodic confusion or word-finding failure, and one-sided weakness or numbness, even briefly, even mildly. None of these symptoms require expensive equipment to detect. They require awareness, and awareness requires someone to teach it. Share this video with someone you love, someone over 55 who might dismiss these signs because they're brief or mild or easy to explain away. That share might be the most important thing you do today. And subscribe if you want to continue receiving the kind of clinical education that your 15-minute appointment simply doesn't have time to give you. Because understanding your body is not a luxury. It is the most practical form of medicine there is.